Okay. So preterm birth prevention. Look at the box. Preterm birth prevention. Prior preterm delivery. Yes. Prior preterm delivery associated with painful contraction. Yes. Prior preterm labor, progesterone, IM or vaginal. If no, then cervical insufficiency and prophylactic circulation should be given. In prior preterm delivery, no. Second trimester transvaginal ultrasound for cervical length. Normal cervical length routine care. Incidental short cervix less than 2.5 cm at less than 24 weeks vaginal position. During the initial prenatal visit, risk factor for potential obstetric complications are assessed to allow for implantation of preventive measure. These patients with prior a cold knife conization is a risk for preterm delivery at less than 37 weeks of gestation. Preterm delivery is a common obstetric complication and a leading cause of neonatal morbidity and mortality. The greatest risk factor for preterm delivery is prior spontaneous preterm delivery, but additional risk factors include tobacco use, multiple gestation, prior cervical surgery, in particular, removal of part of the cervix by cold knife conization for cervical intraepithelial neoplasia can cause cervical shortening and scarring, which decreases cervical tensile strength and increases the risk for preterm labor. For patients with no preterm delivery, a transvaginal ultrasound cervical length measurement is recommended at 16 to 24 weeks of gestation to assess the risk for preterm delivery. Patients with normal cervical length are at a lower risk preterm delivery and require no additional intervention. In contrast, those with short cervix, cervical length less than 2.5 cm on ultrasound, are at high risk for preterm delivery and are offered a vaginal position which can prevent uterine contraction and preterm labor. Okay. Okay. Gestational diabetes mellitus, human placental lactose secretion at 24 to 28 weeks of gestation, 1 hour 50-gram glucose challenge test and 3 hour 100-gram glucose challenge test. First line is diet, second line is insulin, glyburide and metformin. Target blood glucose level fasting less than 95, 1 hour after postprandial is less or equal 140, and 2 hour after postprandial is less or 1 hour 2 hours after postpartum is less or equal 120. Postpartum management fasting blood glucose at 24 to 72 hours. 2 hours after 75 gram GTT at 6 to 12 weeks of visit. At 6 to 12 weeks of visit. This patient has gestational diabetes mellitus, which is increasingly common due to obesity epidemic which is increasingly common due to obesity epidemic. Other risk factors include GDM in a prior pregnancy and prior macrosomic infants. All women require screening at 24 to 28 weeks of gestation. Because GDM is associated with increased risk of gestational hypertension, preeclampsia, fetal macrosomia, and cesarean delivery, patients with risk factor benefit from earlier screening, early second trimester, and rescreening at 24 to 28 weeks if the initial screen is negative. Patients diagnosed with GDM, such as this one, are monitored with serial blood glucose measurement fasting and either 1 to 2 hours after postprandial. Dietary modification: low carbohydrate diet, small meals with intermittent snack is the initial approach to management. However, patients with glucose level consistently above the target range, more than 95, in fasting 1 hour after 140 and 2 hours after 120, such as these patients, require additional pharmacotherapy because dietary modification alone has proved insufficient. Insulin is a first-line pharmacotherapy because it does not cross the placenta and dosing is easily adjustable. Oral anti-glycemic medication, metformin, glyburide, may be used in patients who decline insulin and have difficulty administering and adhering to insulin therapy. Okay, this shoulder dystocia, so be calm. Mm, Shoulder dystocia, breath, do not push, elevate and flex hip, elevate legs and flex hips and thigh against the abdomen, call for help, apply suprapubic pressure, enlarge vaginal opening with episiotomy, then the maneuver, deliver posterior arm, rotate posterior shoulder, adduct posterior fetal shoulder, mother on hands and knees all fours, and replace fetal head into pelvis for cesarean delivery. Okay, so this patient is experiencing shoulder dystocia or impaction of the fetal anterior shoulder behind the maternal pubic symphysis that impairs delivery of the shoulders. with routine gentle traction. Risk factor include gestational diabetes mellitus, as in this patient an associated fetal macrosomia birth weight more than 4.5 kg. Shoulder dystocia is an obstetric emergency that can lead to both fetal and maternal complications. Fetal complications include brachial plexus injury, clavicular or humeral fracture, hypoxic encephalopathy. Maternal complications include fourth grade rectal mucosa, perineal laceration, and PPH. Management of shoulder dystocia requires maneuvers to disclose anterior shoulder and or reorient the fetus to deliver through the widest diameter of the bony pelvis. The initial step is relieving fetal dystocia is macroverse maneuver, flexing the patient's hip, flex, flexing the patient's hips back against her abdomen and applying suprapubic pressure. The macroverse maneuver flattens the sacral promontory and decreases obstruction through the bony pelvis. Suprapubic pressure may then dislodge the anterior shoulder to allow delivery. The combination of these maneuver relieves shoulder dystocia in nearly half of the cases with further intervention. Okay. Initially, it was a bit normal. After giving oxytocin, it becomes fetal late deceleration. So looks like something is causing it. Okay. So these patients fetal heart rate racing, recurrent deceleration, late deceleration more than 50% of the contraction. Late deceleration are a sign of uteroplacental insufficiency and impending fetal hypoxemia and acidemia. These patients' fetal deceleration are most likely due to uterine tachysystole defined as more than 5 contractions per 10 minutes. Uterine contraction temporarily interrupt intervenous blood flow. Excessively frequent contraction as in this patient may cause fetal compromise as a result of decreased uteroplacental blood flow during contraction and inadequate recovery time. Resumption of blood flow between contraction. Although uterine tachysystole can occur in spontaneous labor, there is increased risk with There is increased risk with induced or augmented labor uterotonic agent. Uterine tachycystole is managed with supportive measures, late maternal, lateral maternal repositioning, toccolytics, and discontinuation of the uterine drug oxytocin until the excessive uterine activity and resulting fetal deceleration resolve. Okay, it's oxytocin side effect. This patient this patient had generalized tonic-clonic seizure after induction of labor for preeclampsia. For severe feature, the most common cause of postpartum seizure is eclampsia. Given this patient's normal blood pressure, magnesium level is the therapeutic range for preeclampsia and eclampsia management. Other causes require evaluation. With the sodium 112, patient seizure is most likely due to severe hyponatremia, a rare side effect of the oxytocin. Oxytocin commonly Oxytocin commonly used for induction of the labor and postpartum hemorrhage management and has a similar structure to antidiuretic hormone vasopressin. Therefore, elevated levels can stimulate the renal collecting ducts to increase water reabsorption. This leads to acute hyponatremia, decreased serum osmolarity, and decrease and increase free water movement into the brain cells with resultant cerebral edema and seizure. The risk is rare, but life-threatening side effect is increased with excessive and prolonged oxytocin administration, as seen in this patient who had a 48-hour oxytocin infusion followed by a bolus. Management of oxytocin-induced hyponatremia include cessation of oxytocin infusion and gradual administration of hypertonic saline within 3% saline in symptomatic patients, seizure to raise serum osmolality and reverse cerebral edema. Okay. Okay, pregnancy management in patients with herpes simplex virus. Herpes simplex virus infection. Herpes simplex virus infection before or during pregnancy, no. Routine prenatal care, yes. Antiviral suppression beginning at 36 weeks. Lesion or prodromal symptoms during labor, no. Vaginal delivery. Lesion or prodromal symptoms during labor, cesarean delivery. So this patient has history of genital herpes simplex virus infection with no recent outbreak. During most pregnancy, patient with history of herpes simplex virus infection typically require no additional management compared with uninfected patient. However, beginning at 37 weeks of gestation until delivery, pregnant women with a history of genital herpes simplex virus receive antiviral prophylaxis, acyclovir, valcyclovir, regardless of symptoms. The management is recommended because active HSV and delivery increase the risk of vertical transmission due to direct neonatal contact with viral particles shed from the infected vulva, vagina, cervix, or buttock. Vertical transmission of the HSV at delivery can cause neonatal meningoencephalitis or sepsis, which often results in long-term sequelae, blindness, neurocognitive disability, persistent seizures. HSV prophylaxis reduces asymptomatic viral shedding and outbreak recurrence. Patients with no prodromal symptoms or active lesions indicating low viral shedding have a low viral shedding have a decreased risk for vertical transmission. In asymptomatic patients on antiviral prophylaxis, vaginal delivery is safe and recommended. In contrast, patients with prodromal symptoms or active lesions at delivery are at risk of neonatal transmission and require a cesarean delivery. Okay. Mm, he's hemodynamically unstable. Sorry, she is. Oof. I think I think that blood should be given, isn't it? Yes. Okay. This patient, this pregnant patient with abdominal pain contraction, vaginal bleeding following blunt abdominal trauma, BAT, motor vehicle convulsion, likely has abruptio placenta, placental abruption due to the volume of the blood supplied to the uterus. Abruptio placenta can cause hypovolemic shock from hemorrhage, hemorrhagic shock as seen in this patient with hypertension, tachycardia, and cold extremity. Management of the trauma patient. Management of the trauma patient with hemorrhagic shock requires rapid resuscitation with replacement of intravascular volume, transitioning from crystalloid to blood product as soon as possible. In addition to pregnant patients are placed in left lateral decubitus position if if the spine is stable to displace the uterus of the aortocaval vessel and maximize cardiac output. If hemorrhage or hemodynamic instability continues despite initial resuscitation effort, massive transfusion protocol MTP should be activated. MTP is administered. MTP is the administration of the packed red cell, platelet, and fresh frozen plasma 1:1:1 ratio to avoid the coagulopathy from dilatation of the platelet and clotting factors. Okay, and emergency CS, look at the option A. Emergency cesarean delivery after maternal trauma may be indicated for imminent fetal compromise, like category 3 heart tracing. This patient has category 2 heart racing, like minimum variability. If there is absent variability and deceleration, that means 3, then we should do CS. But otherwise, fetal heart rate is normal with no variable or late deceleration. Therefore, she does not require emergency delivery. It is not abortion because abortion happens before 20 weeks. So she is 24 weeks. It is placenta previa. Okay. And risk factor is prior cesarean delivery. Okay, this patient's vaginal bleeding after 20 weeks of gestation is due to placenta previa, a condition in which the placenta covers the cervix. These patients' risk factor for placenta previa include prior cesarean delivery, multiparity, and smoking. Prior cesarean delivery, multiparity, and smoking. Additional risk factor include prior placenta previa and multiple gestation. Placenta previa has the potential for massive antepartum hemorrhage because cervical manipulation, even minimal manipulation from intercourse, can causes partial placental detachment and painless vaginal bleeding from the intervillous space. This bleeding is primarily of the maternal origin. Therefore, many patients have reassuring fetal monitoring, initially acceleration, no deceleration. Treatment depends on maternal hemodynamic stability, fetal status. Stable patients are managed expectantly as previous, resolved by third trimester. Patients with persistent previa undergo cesarean delivery at 36 to 37 weeks of gestation. Okay.
36-year-old woman gravid at 37.
Is it intraamniotic infection? Her, no, no, not in the answer choice. Intraamniotic infection, I'm thinking because farning is positive. A microscopy show farning and squamous epithelial cell with no. So something, sorry, not always comes with the fever. It is the complication of intraamniotic infection. Placental. I thought in the wrong direction. Amniotic fluid is leaking. Is there any abdominal pain? Okay, abruptio placentae. Okay, in this patient, vaginal pooling of the clear fluid, that demonstrate farning on microscopy is consistent with pre-prom. Farning on microscopy is consistent with pre-prom, preterm, pre-labor rupture of the membrane or rupture of the membrane less than 37 weeks of gestation before labor onset without contraction. Risk factors include pre-prom in a previous pregnancy, antepartum bleeding, and genitourinary tract infection, particularly bacterial vaginosis. Patients with pre-prom are at risk for both maternal and fetal complications, which may require immediate delivery. A common complication is placental abruption, abruptio placentae, premature separation of the placenta from the uterus. Placental abruption can occur with preterm pre-labor rupture of the membrane in earlier gestation compared to term because a small fetal size in relation to the amniotic fluid volume and in intrauterine cavity size. A large a large decrease in amniotic fluid index less than 5 leads to uterine decompression which causes maternal decidual vessels to shear, resulting in bleeding and separation of the placenta from the uterus. As the abruption enlarges, patients are at risk for fetal hypoxia and for possible demise, maternal hemorrhage, and possible DIC. Additional complications of pre-prom include intraamniotic infection, preterm labor, umbilical cord prolapse. Due to their risk of their complication, patients with pre-prom require inpatient management. And you want me to read the other options? Okay, uterine rupture secondary to increased intrauterine pressure from contraction from polyhydramnios, not due to, not due to decompression as in pre-prom. Risk factor from uterine rupture include labor after uterine surgery, classic cesarean delivery, and acute trauma. Neither applies to this patient. Yes, preterm pre-labor rupture of the membrane. Preterm pre-labor rupture of the membrane. Membrane rupture at less than 37 weeks of gestation. Membrane rupture at less than 37 weeks of gestation. Risk factors are prior pre-prom genitourinary infection like asymptomatic bacteriuria, bacterial vaginosis, and antepartum bleeding. Diagnosis is vaginal pooling or fluid from cervix, nitrogen positive fluid, and finding on microscopy. Management is less than 34 weeks, reassuring latency antibiotic and corticosteroid. Less than 34 weeks, non-reassuring delivery should be done. And more than 34 weeks delivery. Which form of delivery? Is it normal delivery like vaginal delivery? Oh, okay. Complication is uh, preterm labor, intraamniotic infection, placental abruption, and umbilical cord prolapse. Okay, is stress urinary incontinence. This postpartum patient with new onset this postpartum patient with new onset leakage of urine with Valsalva maneuver has stress urinary incontinence due to pelvic floor laxity. Stress urinary incontinence is a common uh, following labor and delivery due to two main mechanisms: weakening of the pelvic floor muscle levator-ani muscle complex, which normally support the bladder and urethra, due to increased intra-abdominal pressure with fetal descent and pushing. Pelvic floor weakness causes urethral hypermobility and inability of the urethra to fully compress closed during periods of increased intra-abdominal pressure, resulting in leakage of urine with Valsalva maneuver. Stress injury to the pudendal nerve, which helps maintain continence because it innervates a voluntary contraction of the external urethral sphincter. The pudendal nerve is a main sensory nerve of the pelvis, and damage to it can result in decreased voiding sensation as seen in this patient. Although postpartum stress urinary incontinence increase the risk for chronic stress urinary incontinence, most cases are self-limited because the pelvic floor muscle and the pudendal nerve heal after delivery. Therefore, patients less than 6 weeks of postpartum are managed with observation and reassurance and encouraged to perform Kegel exercise to strengthen pelvic floor muscles. Patients who later have chronic stress urinary incontinence can be treated with continence pressuring and mid-urethral sling procedure to compress the urethra to anterior vaginal wall and thereby decreasing urethral hypermobility. Normal.
Pregnancy.
Is it preterm? Placenta is anterior and low lying. Okay. Mm, Is it PPH?
Yes.
Okay. It's placenta accreta. This patient ultrasound finding consistent with placenta accreta, the abnormal attachment of the placental villi directly on the uterine myometrium rather than the decidual vessels through defects in the decidual. Risk factor include prior uterine surgery, DNC, cesarean delivery because areas of uterine scarring cannot undergo normal decidualization. Patients also typically have concomitant placenta previa because can decrease fundal fundal perfusion and promote abnormal placentation in the lower uterus. Low-lying placenta patients with placenta accreta are typically symptomatic and often diagnosed incidentally on second trimester ultrasound. Common findings include low-lying placenta, signs of abnormal placental attachment or invasion into the uterine wall, such as myometrial thinning and vascular spaces filled with maternal blood. The result of this normal abnormal placental attachment is morbidly adherent placenta that does not spontaneously detach after fetal delivery. Attempts to manually remove the placenta can disrupt the placental lacuna and cause profuse maternal bleeding (PPH). The bleeding can lead to hemorrhagic shock (DIC) and maternal death. Patients diagnosed prenatally typically undergo planned caesarean hysterectomy to decrease these risks, but patients diagnosed at the time of the delivery usually require emergency hysterectomy to achieve hemostasis. Yes, placenta accreta. Placenta accreta attached to the myometrium. Placenta accreta morbidly adherent placenta attachment to the myometrium. Risk factor is placenta previa plus prior uterine surgery, caesarean delivery, DNC, myomectomy, prenatal diagnosis, ultrasound with placenta previa, numerous placental lacuna, myometrial thinning, myometrial thinning, and postpartum diagnosis, adherent placenta PPH. And treatment is caesarean hysterectomy with placenta in situ. Yes, we need to do we need to do delivery via cesarean section, then we should do hysterectomy after that because PPH is the most important risk factor. We may not be able to control the blood without hysterectomy because final uh, term of controlling PPH is hysterectomy. Okay, in pregnancy, worsening asthma, can be due to several factors: altered daily activities, increased stress or anxiety. On, mm, okay. In addition, pregnant patients may discontinue medication due to limited knowledge regarding their safety and concern about fetal harm. Although non-essential medication should be minimized in pregnancy, most asthma medication, including inhaled beta agonist and inhaled beta agonist and inhaled corticosteroid, are safe, and their discontinuation may lead to worsening asthma symptoms, which are associated with worse outcome. Given this patient's pattern of worsening symptom after years of good control, medication discontinuation out of fear of harming the fetus should be considered. The discussion should begin with a non-judgmental inquiry in the patient's use of her asthma medication. The review should focus on when or how often the patient uses both controller and rescue medication. In many cases, mm, providing reassurance regarding the safety of most asthma medication and education regarding the benefits of good asthma control during pregnancy is helpful. Careful follow-up, more frequent visit has been found to improve adherence to asthma exertion. Okay. Okay, can you give me five? I think there is preeclampsia with severe feature. Look at the pressure, hypertension. Okay. This patient has preeclampsia defined as the onset hypertension systolic more than 140 and diastolic more than 90 at 20 weeks of gestation with proteinuria with or without organ damage. Renal dysfunction risk factors include nulliparity, pre-existing diabetes mellitus, CKD, multiple gestation, advanced maternal age, and prior preeclampsia. Preeclampsia is subclassified as either with or without severe feature. This distinction is critical because patients with severe feature have significantly greater morbidity, eclampsia, abruptio placenta fetal demise, and require different management. Preeclampsia with severe feature is diagnosed when more than one of the following is present: severe range hypertension, systolic more than 160 and diastolic more than 110, Most patients with severe feature meet the criterion, but some has milder uh, placental elevation, but some has milder blood pressure elevation, such as this patient headache, severe or persistent visual changes, scotoma, blood vision, and or pulmonary veins. Severe lab abnormalities such as elevated serum creatinine more than 1.1 milligram per deciliter or 2 times of normal, elevated transaminase 2 times of the upper limit of the normal, or placental count less than 1 lakh. Therefore, this patient with creatinine of 1.8 milligram per deciliter and elevated transaminase has preeclampsia with severe features. Okay, next. Okay. This patient with preeclampsia severe onset, new onset, severe range, hypertension, headache, emesis. Hypertension, a leading cause maternal and fetal morbidity and mortality. Severe range, blood pressure more than 160 and diastolic more than 110 increase the risk of maternal stroke, hemorrhagic or ischemic, pulmonary edema, myocardial ischemia, fetal risk, abruptio placentae, and intrauterine fetal demise. Therefore, acute antihypertensive therapy is required. Acute antihypertensive therapy is required to stabilize the patient to reduce the risk of maternal stroke and fetal outcome. First line medication for antihypertensive therapy is IV labetalol, a beta blocker, both uh, a beta blocker with alpha blocking activity. Labetalol is fast acting, effective, and safe during pregnancy. However, in patients with bradycardia less than 60 per minute, beta blockade with labetalol can further decrease the heart rate, resulting in dizziness and lightheadedness. So, IV hydralazine, direct arterial vasodilator. IV hydralazine, direct arterial vasodilator. Hydralazine can cause tachycardia due to systemic due to sympathetic nervous system stimulation. Oral nifedipine, a calcium channel blocker. Although oral nifedipine can rapidly lower blood pressure, this may not able to tolerate oral medication due to nausea or vomiting. Okay, so we haven't give labetalol as because this patient pulse is 54 per minute. So bradycardia is the reason why IV labetalol is wrong. Okay, assessing maternal health, infection, and exposure is an important part of first prenatal visit. As part of this assessment, a standard set of routine screening test A standard set of routine screening tests is recommended for every pregnant patient. Identifying the STD. Where is STD? Identifying STD is particularly important because many maternal fetal transmission are serious yet preventable. Therefore, universal screening for HIV, hepatitis B, syphilis is required at initial prenatal visit. High-risk patient prior STI are also screened for chlamydia trachomatis. Why it is syphilis? Okay, yes. Oh, sorry. I forgot. Okay. Syphilis can result in transplacental transmission with devastating obstetric and preterm labor and fetal intrauterine fetal damage complication. At risk, patients are identified by screening with non-treponemal rapid plasma reagent or treponemal fluorescent treponemal antibody absorption serology. May be used. Either type may be used, but positive result require confirmation with a test from the alternate category because false positive results are common. Treatment for syphilis is with intramuscular benzathine penicillin G, intramuscular penicillin benzathine penicillin G. Pregnant women with penicillin allergy are a unique population. They typically undergo penicillin desensitization for syphilis treatment due to the superior efficacy of penicillin and severity of syphilis related fetal complication. Okay, yes. Routine prenatal lab test. Routine prenatal lab test RHD type antibody screening, RHD type antibody screening, hemoglobin, hematocrit, MCV, ferritin, HIV, VDRL, RPR, HBs, aging, anti-HCV antibody, rubella and varicella immunity, urine culture, urine dipstick for protein, chlamydia PCR, pap test. It is for initial prenatal visit and for 24 to 28 weeks hemoglobin, hematocrit, antibody screen if Rh negative, and 1 hour 50-gram glucose challenge test. 1 hour 50-gram glucose challenge test and 36 to 38 weeks group B streptococcus rectovaginal culture. Okay, look at the box first. Renal and urinary changes in pregnancy, physiologic change, increased renal blood flow, increased GFR, increased renal basement permeability. Increased renal blood flow, increased GFR, increased renal basement membrane permeability, and lab finding decreased serum BUN, decreased serum creatinine, and increased renal protein excretion. In pregnancy, both cardiac and blood volume increase because the cardiovascular system adapts to rising metabolic demands and prepare for expected blood loss from delivery. As a result, other maternal organ system also adapt and compensate with physiologic change in pregnancy. The maternal renal system experience greater renal blood flow perfusion and individual glomeruli filter greater volumes of plasma, increased GFR. Maternal production of blood urea nitrogen and creatinine stays relatively constant, however, due to increased GFR, measured serum levels are decreased. A serum creatinine of 1.2 mg per deciliter, for example, may be the upper limit of pre normal non-pregnant patient but represent marked renal insufficiency in a pregnant patient. Normal is zero point 0.4 to zero point 0.8 mg per deciliter. An additional renal adaptation in pregnancy is greater um, renal basement membrane permeability, resulting in increased urinary protein excretion due to increase in renal function during pregnancy. Patients on medication that are renally excreted require close monitoring and dose adjustment as necessary. Yes, increased, not decreased, urinary protein excretion of up to 300 mg per day occurs in pregnancy due to increased renal basement membrane permeability. Therefore, urine dipstick positive for trace protein are normal in pregnancy. No, pregnancy. Okay. Platelet count are typically normal or decreased, not increased in pregnancy. Sorry. Okay. And D. During pregnancy, total blood volume expands. However, plasma volume increases out of proportion to red blood cell mass, causing mild physiologic decrease in hemoglobin concentration. Lab definitions for anemia vary by trimester, less than 11 gram per deciliter in the first and third trimester and less than 10.5 in the second trimester. So 11, less than 11 in the first and the third, and less than 10.5 in the second. The dilutional anemia protects the mother in case of PPH. Okay, this laboring patient has epidural analgesia placed for pain management, which provides pain relief throughout the labor by allowing to continuous infusion of local anesthetic and opioid via catheter insertion below L4 into the epidural space. These placement allow for a targeted block of pain fibers. This placement allows for a targeted block of pain fibers of labor which corresponds with fetal descent into the pelvis. However, epidural analgesia blocks the sympathetic nerve fibers. Epidural analgesia blocks the sympathetic nerve fibers responsible for vascular tone in the lower extremity, resulting in vasodilatation, venous pooling, and decreased venous return to the heart, decreased cardiac output. Therefore, many patients develop hypotension, a compensatory tachycardia, because sympathetic innervation of the heart via T1 to T4 are unaffected by the block. Those patients with significant hypotension can have decreased placental perfusion, late deceleration, fetal hypoxemia. Treatment of post-epidural hypotension include left uterine displacement, positioning the patient on the left side to improve venous return, IV fluid, and vasopressor administration. Phenylephrine or ephedrine can be given. Okay, yes. Depression of the cervical cord and depression of the cervical cord and brainstem activity occurs when local anesthesia ascends upward. High spinal anesthesia. High spinal anesthesia may offer intrathecal injection, and overdose of anesthetic, resulting in hypotension, bradycardia, and uh, complete motor blockade before the lower thoracic spinal level, upper extremity weakness, diaphragm paralysis. Leakage of cerebral spinal fluid if the dura is inadvertently punctured during epidural placement. This results in leakage of the spinal fluid, which causes a patient to develop postural headache that classically presents at headache that occur that works with sitting, the headache that works with sitting up and improve with lying down after delivery. Hypotension is not characteristics. Yes, this patient has this patient has ovarian hyperstimulation syndrome, a rare but okay, no problem. This patient has ovarian hyperstimulation syndrome, a rare but life-threatening complication of ovulation-inducing. Ovulation triggers agent HCG injections stimulate artificial maturation of multiple ovarian follicles in patients undergoing infertility treatment, can cause exaggerated ovarian response, bilateral annular cystic ovary with multiple follicles, as well as overexpression of the vascular endothelial growth factor, causing increased vascular permeability and capillary leakage. This causes multiple extravascular fluid shift, third spacing, and VGEF, and vascular endothelial growth factor leakage into the intraperitoneal cavity, leading to ascites and abdominal distension. Affected patient typically develop ovarian hyperstimulation syndrome 1 to 2 weeks after ovulation inducing. Symptoms include nausea, vomiting, abdominal pain. Other features include pleural effusion, like tachypnea, decreased breath sound, and increased volume depletion, tachycardia, hemiconcentration, and leukocytosis due to third spacing, because in which in severe cases result in thromboembolism, renal failure, and death. Okay, do you want to stop here? Okay, no problem.